Hello, everyone. First of all, I apologize for not being there in person. Um, I hope everybody can hear me. If not, please let me know. I can speak louder. Anyway, so my charge is to discuss whether or not intracardiac echo is a viable imaging option during implantation of left atrial appendage occlusion devices, and specifically the Amplatzer device. Some disclosures. I will be discussing off-label use of FDA of non-FDA approved devices. So, as all of you know, the current imaging standard at this point is to put the device in using a combination of TE and fluoroscopy. Now, what are the implications of using TE? Well, there are several. First of all, we need an echocardiographer in order to operate the TE probe. So that's physician number 2 in addition to the implanting physician. Second, at least in the United States, we perform the procedure under general anesthesia when using the TE, mainly for patient comfort. We've tried to do this without without general anesthesia and TE, but when the patients are lying on their back with a TE probe, it's certainly much advantageous to have the patient under anesthesia. But the problem with that means that when using a TE, you need a third physician, the anesthesiologist, in order to perform the procedure. So that has issues in terms of scheduling, at least for us. It also increases the time to prepare the patient. Again, I don't know what it's like around the world, but when we use general anesthesia for a case, the amount of time required just to prepare the patient and prepare the procedure and overall lab utilization time increases. Certainly there's a comfort of the patient. In general, patients tolerate sedation better than general anesthesia, at least in our experience. And finally, there's the safety issue of general anesthesia. And you wonder whether or not, particularly in the elderly patients, which are probably the patients that this device is going to be increasingly used in, whether or not these patients are going to be able to tolerate general anesthesia as well as constant sedation. So the question is, why TE? What does TE provide? All of you know there are several things. First, one wants to exclude a left atrial appendage thrombus. Second, we want to assess left atrial appendage size and dimension for proper device sizing. Third, we want to identify the ideal location for transeptal puncture. And again, I use the word ideal. We all know that we can do a transeptal without using ultrasound imaging. However, I think we all also know that if you do the transeptal puncture at the proper location of the interatrial septum, it facilitates the rest of the procedure. Certainly, guiding the pigtail or the sheath to or within the LAA is important. I put to or within because for the ACP, as you know, you don't need to put the sheath far inside the appendage. For the Watchman device, for example, it is important to put the sheath further inside of the appendage. We also need to, as we're deploying the device, we need to assess the device position relative to left atrial appendage and left atrial appendage ostium. Certainly we need to assess device stability, and I realize there's some controversy as to exactly how one assesses device stability. Certainly with the Watchman device, we do tug tests and other such maneuvers. With the ACP, I know some of us use a tug test. I certainly do. I think others don't. But in any event, imaging certainly is useful in that respect. We also use TE imaging to assess peri-device leak. And finally, I think ultrasound imaging certainly minimizes the amount of contrast that one has to use, and I think it also decreases the amount of fluoroscopy exposure. This is certainly true when we use ultrasound in electrophysiology procedures like catheter ablation, but I think it's also true in left atrial appendage closure procedures. This is, of course, you see images, of course, of this is the Plato device, and you see this is a TE image on the left side of the left atrial appendage, which you can see here. This is the aorta, the ostium of the left superior pulmonary vein, and here's the Plato device implanted. I'm showing you this because this is our very first experience with comparing ultrasound imaging modalities. So when we had our initial experience doing implanting the Plato device, we also did, in addition to TE imaging in all patients, we also put the intracardiac ultrasound probe to try to image these patients. Now, what am I talking about? Well, if you look at the next slide here, this is the ICE catheter. All of you are familiar with this, I believe, so I'll go through this very quickly. There are now 2 different ICE catheters that are available, an 8 French and a 10 French. I have to confess my own preference is still the 10 French. I think it's a much better torqueable catheter, but I think the 8 French is also reasonable. It is a 64-element phased array probe. It has four-way deflection of the catheter tip, which I think is actually quite useful. The ability to deflect in all four directions, I think, makes a big difference. And it can be used in combination with a number of different machines, including some newer ones. Now, one question we had is, can we visualize the appendage better from a location other than the right atrium, perhaps the coronary sinus? And we like the coronary sinus because there's very little tissue between the coronary sinus and the left atrium proper. Um, this, unfortunate video is not going to play. I'll go to the next slide. This is the kind of image that you can see. What you're seeing here, the ICE catheter is placed within the coronary sinus, and you're looking here at right around 5 o'clock right here was left atrial appendage. Here we're sort of scanning through the whole atrium. The left atrium, this is left atrial appendage down here, and that's the mitral valve. Now, we did a series back in 2006 where we presented a series of over 100 patients in whom we systematically tried to do ICE imaging from the coronary sinus, and we were able to successfully perform that. This isn't during electrophysiology procedures, by the way, but we were able to successfully perform that in over 90% of the patients. This is back to our initial Plato experience, where in addition to TE imaging, we did ICE imaging, and these are 10 patients, and just to show you that there's a range of different ages, and these are consecutive patients, so they were not selected in any way. And here you see some images. This is again from the coronary sinus. You can see the left atrial appendage. We can measure the width and the depth. Here we're guiding the transeptal puncture. Here you can see the shaft, and here you can see the device itself within the left atrial appendage, and here it's still connected. Here's one example where the device is in a poor position, and then it was repositioned, and here's in the proper position. Now, this is all interesting, and we did 10 patients, and we published a paper on this, but there's some severe limitations. I mean, the fact is we used TE in all of these patients, and all these patients, ICE was there just to visualize. And this was the conclusion from our paper. ICE imaging of the LA was optimal from within the coronary sinus. All the imaging from the proximal pulmonary artery, actually it should be the distal right ventricular outflow tract, provided better visualization of the distal left atrial appendage in cross-section. The LA dimensions, confirmation of the absence of LA thrombus, proper positioning of the delivery sheath, verification of location and stability of the disc obtained by ICE were consistent with the findings from TE. This is the problem. The best we could say was that this was consistent because, again, we used both modalities. So the question is, could we do this now that we have what we consider a better device, a little less traumatic device, the ACP device? Is it possible to put this device in without using a TE probe? And I'm going to show you a bunch of images. This is from a series of cases. Actually, I'm just going to show you a few images. These are from cases recently that we did in whom we did not use TE imaging. We only used ICE imaging, ICE and, of course, fluoroscopy. I'm going to show you a couple of different views. Here's the ICE catheter, and what you're looking at is the ICE is within the right atrium. This is the intra-atrial septum. We're looking out at the left atrium. This is the mitral valve, and you can sort of see it. And we're primarily concentrating on the ostium and the left atrial appendage, which you can see right here. This is the view that you get from the right atrium. In my experience, you don't get much better than this kind of view. And certainly you don't see the depth of the left atrial appendage from the right atrium. This from the coronary sinus. Again, here's the left atrial body. You can see there's very little impediment to the view. And this is the left atrial appendage, which you'll see as we scan back and forth. You can certainly guide the transeptal puncture. Here's the right atrium. There we just punctured. And you can see that we're fairly anterior. This is the left atrial appendage, which is, you can't see very well. But anyway, you can certainly guide the location of the puncture. Here you can see the sheath, and here's the pigtail within the ostium of the left atrial appendage. This is, again, from right atrial imaging. Here, the sheath is at the left atrial appendage ostium. I should say the catheter now is in the right ventricular outflow tract. This is the aorta. This is the left atrial appendage. And here's the sheath just at the ostium of the left atrial appendage. And here we're unsheathing the ACP device. Here's the device itself at the ostium of the left atrial appendage. Here you see the lobe. Here you see the second disc. So this is not a very nice view. Again, it's from the RVOT, but it's still good enough to show you where the second disc is in relation to the left atrial appendage. This, by the way, down here is the left superior pulmonary vein. And here's the ACP, again in the PA view. The device is now deployed, and you can see the device itself, including the left atrial appendage, and here's sort of the distal part of the left atrial appendage. This is the same thing looking from the coronary sinus. The appendage is down here. Here you see the lobe, and here you see the outer disc. You do get the impression that there may be a little bit of leak on this side. In fact, you can put color. Unfortunately, on our particular machine when I was doing this case, our color Doppler wasn't working very well. But still, you get the impression that there's leak. And certainly, if the quality of the color Doppler was better, we would see a little bit of leak. Of course, one question is, does leak matter? And answer is, I don't know. This is from our own paper published in JACC. It's actually published now, showing that in the Protect AF study, whether or not there was a leak or not, as long as the leak was very small, it didn't make any difference in terms of the subsequent event rate. Now, again, this is with the Watchman device. We don't yet have data like this with the ACP device. My guess is, though, it'll probably be similar. And then here's the final position from the CS looking at this device. Now you can see that we used a couple of different views, sometimes from the right atrium, sometimes from the RVOT, sometimes from the CS. But I'll tell you, the view that I like best, that I'm using more frequently now, is a view directly from the left atrium. So what we're doing is we're doing a transeptal puncture, upsizing with the large sheath, the 10 French or 12 French sheath. Then we pull the sheath back, still retaining access, and snake the ice through that hole. So then we have the sheath and the ice through the same hole. We could do separate punctures, but we're just doing it this way. And what you're seeing here is with the ice catheter looking at the appendage. So this is the left atrial appendage. This is the left superior pulmonary vein. This is the ridge. And here's the sheath just at the ostium of this appendage. And using this direct LA imaging, here's the position of the AC of the lobe itself in position. I think this is a reasonable position. And here's the disc itself. So once we deploy the disc, and here this is. And here we're doing a tug test. You can see we're pulling on this. Of course, we can also look at this with fluoroscopy. I'm just in the interest of time, not spending time looking at fluoroscopy images. I just wanted to concentrate on the ice images. And here you can put color Doppler. There is no particular leak in this particular patient. So right now, and this is actually the last slide, we're doing a prospective study where we're systematically trying to assess the ability of our ability to place the device using fluoroscopy and ice alone. I mean, I think all of us have done a few cases now and then using just fluoroscopy, maybe with ice, maybe without ice. Other than, I think, Reddy Meyer, I'm not sure that I think that most of us do use TE in our typical cases. So what we decided to do was, again, do a prospective study where every single patient is, we use ice alone. Now in these patients, and I should say, there is no exclusions. As long as the patient is indicated for left atrial appendage closure with the ACP device, and they have an anatomy that's suitable, and I mean suitable for the device, not necessarily for ice, we're including the patients. Now, how are we doing this? Well, all patients are getting a pre-procedural TE, either the day before or maybe even the day of, but not on the table, not in the cath lab or EP lab, but rather in the echo lab. So, and the purpose of that is to assess appendage size and to exclude thrombus. So we can look at the size and the various views. I didn't mention with ice, one of the problems with ice is you can't rotate the transducer. So you're really only looking at one view from any particular plane. You can move from the CS to the left atrium to the PA, but still at any particular position, you're only getting one plane. And the best you can do is to scan from side to side. So by doing pre-procedural TE, you can get multiple views of the left atrial appendage, and certainly exclude the thrombus. The procedure itself, we're doing under conscious sedation. We're not doing simultaneous TE and ice. Again, the patients do not have a TE probe. We're just using the ice. And I also thought it was important to do it under conscious sedation because that's how we're doing this. One of the advantages of general anesthesia is that you can go apneic, so then you have less movement at critical parts of the procedure. But if we're going to be using ice in the real world, we wanted to do that in this particular study. There are 4 different views that we're looking at: the right atrial view, the view from the distal RVOT or the proximal or the pulmonary artery, from the coronary sinus itself, as well as directly from the left atrium. And I should say, I'm not going to present the data because we're not done with the study, but let me just give you my own gestalt of these various views. The right atrial view I find not particularly helpful. The only time we really use the right atrial view is during the initial part of the procedure when we're guiding the transeptal puncture. The RVOT and particularly the PA view, when you put the ice catheter way into the left pulmonary artery, just above the left atrial appendage, I find that a very nice view, particularly for ruling out clot in the left atrial appendage. So I think that I really like that view. But to guide the implantation itself, it's okay, but it's not perfect. The CS view I also like. I showed you a couple of images. It's a little bit different than what we're typically used to compare. That is the 45-degree TAE view, which most of us use, I think, during the implantation itself. However, the CS view is nice. One problem with the CS view is you can't always get the CS in the anatomy. I'm sorry, you can't always get the ice probe in the CS, depending on the anatomy. But most of the times you can if you work at it. Finally, the direct LA view, I like this a lot. In fact, this is turning out to be the view that I prefer in terms of the bulk of the guidance of the implantation of the device itself. It gives you a view that, in fact, is even better than the TE view for guiding the implantation itself. Um, and I think it's probably going to end up being the sort of the workhorse view that we use. In our study, all the patients will get repeat TE imaging and follow-up to verify device positioning, and to make sure that it's the same as what we would expect. So with that, I think I'll go ahead and stop. I hope there's somebody in the audience because I can't hear anything. I hope I've been talking to somebody.
Hi, Vivek. Can you hear now?
Yes, I can hear. I can hear.
It's John Kemp speaking to you. I'm one of the chairs for this particular session. We're
Oh,
sorry
hi, John. How are you?
I'm well. I'm sorry that you're not here for two reasons. Firstly, we'd like to see you and like to have you here. But secondly, your slides have been a bit small for us, so we've not necessarily seen all that we would have liked to have seen. It may be that some of the questions you get might have been answered by seeing the slides better, but just to explain to you, if people ask questions that you thought you'd already explained, can I just start the questions by asking how much fluoroscopy and how much contrast are you using with the scheme where you're using both TE and ICE together?
No, it's a good question. Fluoroscopy itself, we're not using that much fluoroscopy, and again, I can't give you exact numbers, but the typical case is less than 10 minutes of fluoroscopy. And I think that's perfectly in line. Certainly, it's in line with what we used to do in the past. We're spending probably a little bit more time than we otherwise would in regular cases, just because we're trying to systematically position the ICE catheter in all of the different locations to try to really understand what the images look like. But as we go further along, it's very clear that there's certain views that there's no point spending too much time on. So for example, from the right atrium, there's no point spending too much time trying to identify the appendage. It's not going to be that good anyway. And in the CS, for example, I don't think it even makes that much time. It makes that much sense to spend too much time entering the CS. Contrast. Contrast, we're actually not using very much contrast at all. It's actually very similar to what we typically use with TE imaging. What is that? It's on the order of somewhere around 50 to 80 cc's of contrast in the majority of the cases. I think that's well in line with most patients. Now, I remember one patient that we had whose creatinine was a little bit elevated. So in that patient, we used even less contrast. We diluted it, used higher quality fluoro, and ended up using less than 30 cc's of contrast. So I think that by paying attention, I'm not sure that we lose that much. Again, we're about 3/4 of the way through our study, so we'll have the final data hopefully in a month or so.
Thanks very much. I'll now ask if others have questions for you. Anybody in the audience that would like the microphone? Yes.
Jacek Baranowski, Linköping, Sweden. When we position the plaque under TE, we use the circumflex artery as a landmark. What's your experience with ICE? Can you have similar views or?
Yes, I don't know if you can see the image again. Hopefully you can see the PowerPoint presentation still. Can you see it right now still,
yeah,
John?
We can see it.
Okay, I don't know if you can see my thing, but this is so this is a direct LA imaging, and actually the circumflex is right here. So the image is actually very similar to what you see with TE. And so at least from the direct left atrial view, you actually get a very, very similar view. I'm sorry, similar to the 45-degree view.
Thank you very much.
I'm just wondering, doing an ice, you need to manipulate to get different views. When you're actually having both the sheaths and the catheter, do you have to make maneuvers? Is how you...
Yeah, no, it's a good point. Look, so let's just go through the various parts of the procedure very quickly. Guiding septal puncture, I think, is pretty straightforward. I think many people have done this in the audience, and I won't spend too much time on it. It's relatively easy. You can park the ice catheter in the right atrium, find the position you want, manipulate, and then typically before we actually puncture itself, we scan back and forth with the ice probe to make sure we're at the right angle, and then perform the puncture. And as I said, the workhorse view that I like now is directly from the left atrium. What we're finding is once we position the ice across the transeptal hole, then the key is to deflect the ice back, because if the ice is too close to the appendage, then everything is near field and you have no perspective of what's going on. So you actually have to do a retroflexion, sometimes shift to the right or the left, and that'll give you the proper position to look at the left atrial appendage. And once you position there, then you can pretty much leave it, make mild manipulations left or right. And in fact, most of the cases has been a single operator procedure. Sometimes there's a second operator standing next to the primary operator, and that person I may ask to rotate the ice left or right a little bit, but most of the times it's actually been a single operator. So it hasn't been a big issue to do this simultaneously. Again, we haven't done 100 cases. We've done about 15 cases so far. So it's not a huge number, but at the same time, I think it's a reasonable number. There's one other point I should make. I forgot to point this out, which is some of the limitations. Obviously, we're still learning about the safety and et cetera of this approach, and so far it seems to be quite safe and effective. There are cost issues, of course. The ice cap is certainly more expensive than a completely reusable TE probe. And you have to balance this. In the United States, if you have three different physicians as opposed to a single physician, that certainly impacts the cost of the procedure. Also, at least at our hospital, we're able to reuse the ice probe 2 or 3 times. I mean, not indefinitely, but about 2 or 3 times. And that brings the cost of the catheter down considerably, by about a third. And this, by the way, we can't do it in-house. There are re-sterilizing services that they're able to provide the catheter for us. And by decreasing, again, the cost of the catheter to just about $1,000, it becomes a much more economically feasible solution. But I do acknowledge and accept that the cost of the probe itself can be prohibitive. Again, depends on the economic situation, the individual institution, and the individual country.
More questions?
Ice seems to be a reasonable alternative to TE, but the fact that you don't have a 3D possibility, I think that makes somehow not at the equal level with TE.
I'm sorry. Is the question?
You don't have 3D.
3D TE.
Yeah.
You're saying. Yeah. Well, I don't know. Maybe you can help me with this. We do have the 3D TE, but I have to confess I don't really use the 3D TE that much to help me, and maybe I don't know how to use it very well, and I certainly accept that possibility. But at least in our experience, the 3D TE certainly gives us beautiful pictures of what's going on. But in terms of the actual operational issues, guiding the transeptal puncture location, which I think 3D TE can help, but I think even with 2D are okay. But the other parts, positioning the lobe in the ostium of the appendage, and particularly positioning as relative to the left circumflex, as the earlier physician pointed out, that I think 2D is actually more helpful. And in fact, the stability tests and the other tests, I actually find the 2D fairly helpful. And again, I'm not saying, you're absolutely right, we don't have 3D capability with ICE, at least not yet. But I haven't missed that, and maybe again that's because I don't use the 3D part of the TE for much other than taking a very pretty picture at the end. So maybe I could ask you, what part of, how does 3D TE help you beyond 2D TE?
Can you just answer that?
I was going to ask you another question. When you are using the largest sizes of the ACP devices, you will have a 13 French sheath across the septum,
right,
and you will have a 8 French ice catheters through it. So one question, do you really need to dilate it, and how much? And when you come back with your sheath and your ice catheter, will you have a significant ASD that you need to close, or what about the hole afterwards?
Yeah, it's a good question. I don't have a definitive answer yet, but let's just go through what the data is. We know that you can do very large transeptal holes. We're talking about 16 French, 18 French, and tandem heart, it's even bigger, without untoward consequences, without long-term residual ASDs. And what we're doing here is a 12 French with an 8 French next to it. 12 plus 8 is not 20 in that situation, as you know, because a 20 French hole is bigger than a 12 and an 8 that are sitting next to each other. We don't actually dilate, by the way, just to be clear. We put the 12 French across, leave the wire, pull the sheath dilator back, so just the wire is the hole. Then we manipulate the ice catheter through that hole, then push the sheath back over. So you don't need to dilate with the larger French. You're doing this serially. But I think it's a very important question. We need to understand how long it takes these transeptal holes to close, whether it's the same sort of time frame as we've seen with when we do a single 12 French transeptal hole, and we have data from that from both the Watchman device as well as other devices. The second possibility, we haven't explored this itself, but in AF ablation, as we often do, 2 transeptal punctures is really the norm in our procedures. So we do 1 transeptal puncture for one sheath, the second for a different sheath, and it works quite well. One possibility, of course, if one wants to do this and is worried about a larger hole, is to do a second transeptal puncture and put the ice through that hole. My own feeling is that I'm not terribly worried about dilating the hole a little bit bigger. My guess is that it's going to be, based on experience with AF ablation, etc. My guess is it's going to be the same as just a single transeptal 12 French hole. But again, we need to get the data, and we'll follow these patients.
Further questions? If not, could I get the microphone back? Thank you very much, Vivek. I think we've exhausted all the questions in the audience, so thank you very much for coming to us via Skype or whatever it is. We've enjoyed your contribution. Thanks very much. And
thank you very much, Sean. Again, I apologize for not being there in person, but thanks again for the invitation. Thanks to St. Jude for having this meeting. I wish I was there for all of it, and also thanks to the technical people who actually made this happen really at nearly the last minute. Thanks again.
Thank you very much, Vivek. Bye for now. Bye-bye.
Bye now.